So cough is a vital protective reflex to prevent aspiration and enhancing airway clearance. Chronic cough is defined as one lasting for more than 8 weeks. It is reported by up to 10 to 20% of adults. Cough is a symptom of an underlying pre-medical condition. The commonest symptoms associated with cough would be reflux symptoms, symptoms of a postnasal drip or allergic rhinitis, or in some instances, symptoms of synovitis. In addition, you would produce phlegm in a small proportion of patients of cough. This is generally due to an underlying lung parenchymal disease. In a small proportion of patients, you can have systemic symptoms like fever or generalized body ache, which is generally associated with an underlying chronic infection, which may be responsible for the cough. The commonest causes of chronic cough are based on the various organs that might be affected, which would exhibit symptoms of cough. So going in order of the most common, reflux disease is associated with an increased incidence of cough. This occurs either because of gastroesophageal reflux disease or laryngoesophageal reflux disease. In addition, asthma syndromes, which include either cough variant asthma or classical bronchial asthma, can be associated with persistent cough. Rhinitis or postnasal drip is also associated with cough. Other common non-pulmonary reasons for cough would include drug-related, which is predominantly secondary to ACE inhibitors, smoking-related cough. Now we move on to the pulmonary reasons for cough, which include respiratory conditions such as asthma, COPD, bronchiectasis, pulmonary fibrosis, and in rare instances, lung cancer. There are non-pulmonary reasons for cough, which commonly include heart diseases, liver and kidney diseases, and in a very small proportion of patients, certain autoimmune conditions such as rheumatoid arthritis or lupus. People should seek immediate medical attention when the cough is associated with sudden onset breathlessness or other systemic symptoms such as fever or production of significant amount of phlegm in their cough. In individuals with underlying liver disease, chronic kidney disease, or who are immunosuppressed because of other drugs, they should seek immediate medical attention to avoid further complications to their underlying disease. The guidelines published for management of chronic cough include a pathway of investigations. A detailed history and physical examination is the first step of any assessment of patients with chronic cough. This is followed by a simple chest radiograph and spirometry. This would help us identify if there is presence of underlying bronchial asthma responsible for the cough. If it is not bronchial asthma, we would investigate further by doing a CT scan of the sinuses and of the chest to help us identify if the sinuses are responsible for your cough. If indeed both these investigations are negative, we would arrange for an endoscopy to understand if this was reflux-related cough. In addition, further investigations in the form of CT scans of your chest, also scans of your heart, can be performed to understand if these were the reasons for your chronic cough. In up to 15% of patients, all the investigations come back to be normal. In these small proportion of patients, we would make a diagnosis of chronic hypersensitivity cough, which is idiopathic, which essentially means there is no known reason for the cough. These patients are managed symptomatically. I follow the principle of treating the underlying territory which is responsible for the cough. So for instance, if this is bronchial asthma or cough variant asthma, I will initiate the patient on a steroid-containing inhaler. This would help in reducing the intensity and frequency of the cough. If the patient presents with symptoms of postnasal drip, allergic rhinitis, or symptoms of sinusitis, I would provide them with nasal sprays containing steroids or provide them with antihistamines. If the cough is secondary to reflux-related disease, I would consider starting the patient on a proton pump inhibitor or gastric motility agents. Obviously, if this is a drug-related cough secondary to an ACE inhibitor, I would discontinue this drug. In smoking-related cough, I would consider advising or encouraging the patient to give up smoking. If indeed the cause of the cough is secondary to an underlying lung disease, such as COPD, I would provide appropriate management for the underlying COPD. Frequently, cough with phlegm could occur secondary to a condition called as bronchiectasis. This condition responds best to chest physiotherapy and postural drainage. I would recommend that treatment via a referral to a chest physiotherapist. Last but not the least, in individuals with chronic hypersensitivity cough, which is these days classified as idiopathic cough, I would provide small doses of opioids to help with suppressing the cough, as mentioned previously, to bring about symptom control.